welcome back to our high-yield review. Today, we are cracking open the case files on two really tricky subcutaneous fungi that you absolutely positively need to know for your exams. We're talking Sporotrichosis and Rhinosporidiosis. Let's get into it. Okay, so let's start with two classic clinical vignettes. You've got a gardener with these strange lesions marching up their arm, and then a swimmer with a big, bleeding polyp in their nose. What's the connection? Well, these are the exact kinds of scenarios that should immediately get your brain firing on our two culprits for today. So first up, we've got case file number 1, Sporotrichosis. And you gotta love its nickname, the rose gardener's disease, because it gives you a massive clue, right? You should immediately be thinking about a patient who works with plants, with soil, and gets some kind of minor cut or scrape. All right, let's nail down the definition. The fungus we're dealing with is Sporothrix schenckii. But the absolute key phrase here, and I mean star this, highlight it, is thermally dimorphic. It literally means it has two forms depending on the temperature. This is not just a random fact, it's going to be crucial for understanding how we diagnose it later on. So how does this whole thing go down? Let's trace the steps. It all starts with something simple, like a little prick from a rose thorn. But see, this fungus is smart. It comes equipped with enzymes that let it chew through the local tissue. And then, and this is its signature move, its calling card, it starts to travel. And it doesn't just spread randomly. It follows the lymphatic channels, creating a distinctive pattern. Now, what's really important for your exams is knowing how this disease can show up. The lymphocutaneous form is the classic, the one you'll see about 80% of the time. But don't sleep on the others. For your multiple choice questions, you need to create these little associations in your head. Think osteoarticular in patients with a history of alcoholism, pulmonary in those with COPD, and the scary disseminated form in anyone who is immunocompromised, like a patient with AIDS. Okay, this slide is pure high-yield gold. When you see that pattern of lesions spreading up a limb, we call that a Sporotrichoid pattern. But, and here's the catch, Sporothrix isn't the only bad guy that does this. You have to know the differential diagnosis. Just remember the mnemonic, send nudes, my love. That's S for Sporothrix, N for nocardia, M for Mycobacterium marinum, and L for leishmania. Seriously, lock this one in your memory. It will save you on exam day.
And here it is. This beautiful star-like thing is the histological finding you dream of seeing. It's called an asteroid body. Right in the center, you have a cigar-shaped yeast cell, and radiating out from it are these pink arms, which are basically clumps of antibodies and immune proteins. This whole immune reaction has a name, the Splendor-Hopley phenomenon. This is a classic must-know image.
Remember we kept saying thermally dimorphic? Well, this slide shows you exactly what we mean. It's like a Jekyll and Hyde situation. On the left, at warm body temperature, 37 degrees Celsius, it exists as a yeast. That's our asteroid body. But on the right, when you grow it in the lab at a cooler room temp around 25 degrees, it completely changes and grows as a mold, forming these delicate flower-like clusters. Yeast in the heat, mold in the cold. So here's your lab diagnosis cheat sheet. You might try looking at a direct smear, but honestly, the sensitivity is pretty low. The real money is in the histopathology, looking for those classic cigar-shaped asteroid bodies. But the gold standard, the definitive diagnosis, is culture, and you have to prove it's dimorphic. You need to grow the flower-like mold at 25 degrees and the creamy yeast colonies at 37 degrees. Thankfully, the treatment is pretty straightforward. For almost every case of sporotrichosis, your go-to drug is Itraconazole. Easy enough, right? The only time you really need to change things up is if the infection gets really bad and disseminates throughout the body. In that case, you have to bring out the big gun, Amphotericin B. Okay, let's switch gears completely. We're moving on to our second case file. We are leaving the rose garden and heading straight for the water. Meet our next organism, the pond dweller. Now, the first thing you need to know is the agent Rhinosporidium seberi. But wait, there's a catch, and this is a potential exam trick question. For the longest time, everyone studied this with the fungi, but we now know it's actually an aquatic protistan parasite. That little reclassification is a perfect detail for them to test you on, so remember it. The epidemiology here basically tells the entire story. The source, stagnant, murky water. The patient history almost always involves bathing or swimming in a contaminated pond. The presentation, a big, crumbly polyp that bleeds super easily, usually right in the nose. And you'll see this almost exclusively in specific endemic areas like Sri Lanka and southern India. And this is the money shot for diagnosis. What you are looking at is a biopsy filled with these massive, thick-walled circles called spherules, or sporangia. And they are just jam-packed with thousands of tiny little endospores. Now,
Here is the absolute most critical point. You cannot culture Rhinosporidium. It doesn't grow in the lab. So your diagnosis depends 100% on finding these structures in a tissue sample.
So if you can't culture it and it's not really a fungus, how do you treat it? Well, you can't just throw antifungals at it. The treatment is purely mechanical. You have to surgically go in there, cut out the entire polyp, and then burn the base with cautery. And even then, you have to warn the patient that recurrence is really, really common.
All right, it's time for a rapid-fire review. Let's put these two organisms head-to-head and really hammer home the key differences you are going to be tested on. This is the final showdown.
This table right here is your ultimate exam cheat sheet. Let's run through it. Source, soil versus water. Lesion, nodules marching up an arm versus a big bleeding polyp in the nose. Histology buzzword, asteroid body versus spherable. Can you culture it? Yes, for Sporothrix, a big no for Rhinosporidium. And the treatment? Antifungals versus surgery. If you know these 5 differences, you can answer any question that tries to make you distinguish between the two. And to leave you with one final thought to chew on, that classic asteroid body, that Splendor-Hopley phenomenon, it's not actually unique to Sporothrix. So here's your homework. What other organisms can give you that exact same picture under the microscope? Figuring that out is a great way to test your deeper knowledge. Thanks for